I am the Regional Learning Coordinator for Social Prescribing in London. That role has sort of evolved over time, but essentially it's an NHS England associate role, and it's the function of it is to support link workers across London. We've done that through a number of different ways. One of the ways is hosting drop-in peer supports, and I can see some faces in the room right now of people that are coming along to those sessions. We have a newsletter that goes out. We've given one-to-one support to a number of link workers and supported link workers in their areas set up their own peer supports for their boroughs. And one of the things that came out of the peer supports that we were running was there seemed to be a number of different themes that were coming up time and again. And we felt like it was a really, it could be a good use of everybody's time if we hosted a monthly webinar or a monthly peer learning session where we could bring a number of different people together to discuss the themes. As we all know, there's link workers are being PCNs that you guys are embedded within are thinking about how to support people who are on waiting lists or people who have a number of different medical issues. And I thought it would be useful to bring everybody together to talk through. So some of the things that we've covered in the past are things like how to end with clients, motivational interviewing for link workers, supporting individuals who migrants or people with refugee status, and so a couple of the sessions that we'll be running over the next few months will be focused on the long-term conditions or the so we're looking at cancer today, and I think we'll be looking at diabetes early next year. Could you go to the next slide please, Justina? So really I should say Justina Sobotka. Do you want to introduce yourself, Justina?
That's fine. I'm Justina. I'm responsible for many different projects in the Healthy London Partnership supporting social prescribing, but one of them is organising our sessions. So if you have any questions or any ideas what we could do as the next subject, please do contact me. Or if you'd like to contribute, you know, presenting, sharing resources, please feel free to contact me anytime.
I think it's worth also saying that Justina was one of the link workers that was part of this community of practice, and she joined our team earlier this year and has been really instrumental in sort of representing link workers' voices in some of those meetings that we have and helping shape some of this support. Today is a really informal session. It is Justina's worked really hard bringing together some speakers, some individuals that are supporting individuals with cancer. We've got some link workers or services that have specific cancer social prescribing link workers, and there'll be an opportunity to sort of ask some questions to some of the speakers or share some of your own examples at the end of the session. We're recording today. All of the resources that are discussed in the chat or by any of the speakers we'll happily share after the session. This all gets uploaded to YouTube and the Healthy London Partnership website, so it can be watched again or passed on to people that you think might find the conversation useful. I think the important thing to say is it is a conversation. Please use the chat to talk to each other. If any of you want to change your names on your login to which borough you're from, sometimes it's nice just to use this as an opportunity to meet some other link workers as well and connect with people in areas close to you or that might be talking about experiences you want to find out a bit more about. So use it as an opportunity to network with each other as well. If you've got any questions, please feel free to put your hand up or pop questions in the chat. I'll be picking up the chat. But yeah, let's move over to our speakers. Just want to, oh, sorry, we've got a poll actually. One of the things that we wanted to understand was how confident you are supporting people with cancer. So we know that a number of GPs, when they're thinking about social prescribing, they're wondering which patients they might send your way if they have if they're thinking about social prescribing through the clinical lens, which we obviously try and encourage them not to, but and interested to hear from you about how confident you feel supporting people that have a cancer diagnosis. I think the other thing to say is that I definitely in the early stages where link workers were coming into primary care networks, they didn't have, everything was very new. Perhaps some of those link workers didn't have access to GP records. More often than not, they would be finding out somebody had a condition like cancer by accident, perhaps, so they didn't have access to the EMIS records. So I think one of the things to say is that it is really important that you guys understand the people that you're getting referred over to you. You understand a little bit about, whilst you're tackling their social issues, about, you have some awareness about some of the medical issues that they're facing as well. So that's really interesting. So majority of you are neutral or less. It'd be great if you could pop in the chat what you're not so confident about, what are your concerns, what, in fact, actually take yourselves off mute. I'd be interested to hear from anybody. What are you, what are some of your concerns?
Hi Lianna, it's Caroline.
Hi,
My concern would be understanding what the process is for them as patients, and how we as social prescribers are able to facilitate their journey, you know. I don't know anything about cancer services, but I've had family members who've had cancer, so you know, it's how emotionally how they get affected, but what cancer services are available, how do you support them? That's my real concerns. Not that I don't have any concerns. I mean, I'm quite confident in speaking to people and listening, because that's part of our role, but actually having the relevant information to pass on to them, that would be my concern.
Yeah, interesting. Anybody else?
Hello.
What's affecting your confidence?
Hi, it's Elaine here.
Oh. Hello.
Hello, it's Elaine here. Can you hear me?
Yeah, we can hear you.
I think for me, it's patients that have been referred who are receiving palliative care. I find that quite not mind-blowing, but tricky to navigate. The support quite often I'll get a referral for liaising with other agencies like Mediquip, for example, to make the patient more comfortable. And sometimes it's other admin people calling me to support them, but I don't know enough. I don't feel I know enough, and it's difficult. I find it difficult talking to those that you know, they're on this sort of end of life journey. Just wanted to share that.
Yeah, it's interesting. I think definitely we've got some speakers today that can speak to some of that. Any other examples of things?
Yeah, hello, I don't know if you can hear me. I tried to speak before, but it was, I think we spoke exactly the same time. So, hi, by the way, Lianna, I haven't seen you in a long time. But, for me, it's very similar to the last person who spoke. So recently I've supported 2 people with stage 4 cancer, and wasn't really told enough information, and actually found out in the appointments that it was like incurable. And then, you know, it's knowing what language to use with that person, and also knowing how to direct them to the right services, because, you know, that person doesn't always know kind of how much longer they've got left, and that's come up in our appointments of just going, well, what do I do with my life now that I don't know how much longer I have left? What do I fill it with? So that's become like one of the trickiest things for me to deal with, and to know where to. Luckily in Richmond, which is where I work, we have quite a lot of services. And I've linked up with like the Maggie Centres, the Mulberry Centre in Hounslow. So we have those services, which is fantastic. But it's when you're in that appointment and you didn't know quite how, you know, far that person was on their journey, and knowing what language to use, what's appropriate. And obviously sometimes you learn that from the person, but it would be nice to learn a little bit more about what to say and how to be respectful to the fact that they, you know, have been told that they are going to be living with this illness. And
yeah, really, really important language, and the language you use and how to navigate those conversations, I think, is really important. Rebecca's just put something in the chat around understanding the definitions, the differences between palliative care, end of life, terminal, and are these things that you can know, I'm guessing, before you're working with a patient, or is this something that's going to come out naturally in your conversations with them, and how that's going to inform the support, the conversations you have, the language you use, and the support that you connect them with. I'm really
surprised that people are getting referrals when people have already been referred to a palliative care team and you're having to Mediquip and things like that. Because certainly palliative care teams, typically that would be their role, would be to be supporting the patient and making sure they've got the benefits and doing the.
I think there's a really key point here that as a social prescribing link worker, people will send you things that are not really your job to manage, and that you've got to have the confidence to say, this is this is what I do, and send it back, because you know that's really very, very important.
That's what palliative care do. They make sure that people have their PIP in place, their blue badge in place, their medical equipment, their the hospice and the support. You know, certainly for the patients that are terminal stages, I would send that back. I wouldn't want my team with
equipment is usually district nursing, but I mean, I think the thing is, send it back to the person who sent it to you. You know, send it back to the GP. They have these needs. Please, can you address? You do the things that are yours, and you send back what isn't.
I'm just conscious we've got a couple of people talking today. I think let's go on to the first speaker, and we can definitely, this is really useful discussion. We can come back. Can you go to the next slide, please, Justina? So we've got Nicola Weaver from Macmillan.
Yeah, that's me.
Hi, Nicola. Welcome.
So I'm not really from Macmillan. I'm a GP, and I've been I've combined the work as a GP with other things over a long period. So after I did a public health master's about 20 years ago, so I've been working in the development of social prescribing for the last 10 years, first in the Northeast, developing teams before it was kind of recognised so much by the government, not to say that it hasn't always been there in one form or another. But since in the last sort of 4 or 5 years, I've also combined that with being the Macmillan GP clinical cancer lead in Southwark, and have now a role with Macmillan in South East London to try and improve the availability of social prescribing for people with cancer. So just looking at, you know, the things you're saying, there's obviously lots of points in the journey when you could be helpful to people, but I always feel that the first message is really just to say that cancer is really, in many ways, just like any other disease. And as a social prescribing link worker, it's nice for you to understand processes because it makes you feel more comfortable, but you don't need to know very much about cancer to be able to help somebody, because the things that happen to them are very similar to people with other conditions. And I was thinking that, I guess with cancer, often it's a sudden diagnosis, so people are in a bit of a state of shock if you meet them at the beginning, but that isn't really too different to somebody having a heart attack in midlife, or you know, there are other settings where you can kind of find a comparison. So just to kind of go back to the cancer, these are the times at diagnosis, during treatment, at end of treatment, life beyond treatment. These are all times at which you can helpfully get involved with people. So at diagnosis, it's often just about the fact that they suddenly might not be able to work, or they might have financial issues. There are important things you could do around promoting healthy lifestyle and exercise, because there's good evidence that at any point in treatment, being fitter gives you a better outcome. So thinking of your standard exercise referral processes, most of the borough-based exercise services will include people who've got, I think it's MVQ level 4 now, able to talk to people with cancer. during treatment, what tends to happen is that people are very involved with the hospital. And when they're involved with the hospital, they should all have a clinical nurse specialist attached to them. And there was another point, I think, just in the chat there about not understanding where people are in their journey. That would be your main point of contact. And they should have somewhere in the stuff they've been given a contact number for a clinical nurse specialist. If they don't, the hospital, generally they can ring the hospital, you can ring the hospital and find out who that is if you were going to go that far in terms of helping them. But during treatment, the main point of contact should be that clinical nurse specialist, so that, you shouldn't be needing to take part in the process of delivering healthcare. At the end of treatment, there is now a process where the hospital teams, the tumour teams, carrying out a health needs assessment, which you can see on this slide, the outcome from. There's actually a much bigger pack of information, which I hope that will be shared with you, because it does explain a lot more about the different bits and pieces. So in that, there is a copy of a typical questionnaire that the nurse specialist will go through with a patient at the end of their active treatment. So that would be, it might be at more than one point during the treatment that they would do this, but typically it would be the end of the chemotherapy when they were about to be discharged from hospital care. And if you look at the list of things that appear on here, there are some that obviously would not really have anything to do with your role, but others like money, finance, fear or anxiety, worry about the future. Loneliness comes up. It isn't shown on here, but there's a big problem of people just feeling like they don't know how to get back into the normal world after they've been involved in such intensive treatment. Can you go on to the next slide? So in this short time I've got to speak, one of the things I really want to communicate to you that there are loads of resources, so that people come to you and it's stuff to do with cancer. You can always go to the Macmillan support line, and it's a shame the number isn't on here actually. It is in the main pack, and it is very easy to find. You just Google Macmillan contact number. There's a single number for everything for Macmillan. So if you ring that number, somebody will direct you to one of these services if it's needed. So there's a variety of things. There's a lot of support around finance and the kind of grants that are available to people, or the benefits that are available to people who've got cancer. There's also, I think what's really useful, there's now an online forum where people can go online and chat, and it's actually supervised by a qualified nurse. So just the entries are being checked to make sure that people aren't being given the wrong advice by people who've just happened to be on there. But the online communities have been used a huge amount during the COVID lockdown, and have been really valuable to people. And again, that's kind of illustrated in the longer pack of resources that I'm hoping you will receive. So
just to say that we will definitely be sharing all those.
That's good, because I mean, I think
I've put the number in the chat as well.
Great, that's great. I mean, I think I would stop there actually and just see, what thoughts does that, bring out in people that are listening? What comments have you got? And let's just kind of talk about the things that, this makes you think about in your own context.
That makes a lot of sense. It's really helpful, because to understand that you've actually gone through the start of their journey, then what happens in diagnosis, and whether we're part of that. What I've seen on one of the forums is, not Macmillan forums, but our social prescribing forum, is that some social prescribers are being asked to do care reviews with cancer patients. Now, I'm not sure if that's something that we should be doing, but it sounds like that the cancer patients have a lot of support. And like you said, I've not been involved in that. And so to know that at the beginning, at the diagnosis and during the treatment, they'll have a clinical nurse specialist is really helpful. Thank you very much.
It's interesting that you mentioned that they're doing cancer care reviews. So social prescribing, as you'll all be aware, has got a lot of different meanings to a lot of different people, and in different settings and different boroughs, different kind of arrangements will be made.
Yeah.
So in Southwark at the moment, we, from our 2 main teams, we've just got 2 centralised teams. 3 or 4 people have decided that they'll take the lead for the team on cancer, and have got a bit more involved. And the cancer care reviews that we do in primary care, there's nothing really very complicated about them, but the standard kind of template does involve a number of medical questions. So if you were being asked to do that, it should be clear that you're not being drawn into the medical side of that review process, that it's about talking to people about their experience having come back into the community. I have a really good example of this. One of my cousins was a cancer nurse at the Marsden, which is, one of the main cancer nurses in the country, and then she's just finished chemotherapy for breast cancer. And when she finished her treatment, she said she has, exactly as people decide, the feeling that she's fallen off a cliff, because she's well, not completely well, still quite tired, a bit bemused by the fact this has happened to her. And really, none of those things are things that medicine can help. It's about kind of regaining her confidence and getting back to a normal life. So nobody's kind of immune to these sort of things that happen to them, and medicine doesn't have the answers to.
No, you're right. Yeah. I mean, I understand that where we could come in as social prescribing, as far as supporting people, and from a viewpoint of motivational interviewing, we could ask those right questions and perhaps change someone's viewpoint of their life. So I could see it that way. Yeah, thank you.
Just for time, do we have? I'm just Cassandra's also got to go at 1:05. Did you have some top tips, Nicola? Is it worth running through the?
The next slide was the top tips. Now I have to say the top tips which I've given you in this slide are the Macmillan. I think it's the next slide along. It's a kind of This is a slide coming gap. It's Macmillan's kind of ideal scenario kind of top tips, whereby every person with cancer was intimately kind of involved with its support from a social prescribing link worker. So I wouldn't want this to put people off when you look at it and think, gosh, that's a huge amount I'm expected to be doing. My top tips personally would be to say, just don't be afraid of dealing with cancer. It's not really in many ways that different to other illness processes. It's the impact it has on people's life. Be ready to send things back if they're not in your area of expertise, and to not undervalue the impact of just even the conversation that you have with somebody about how that can improve their confidence to handle things. In the big social prescribing project I was involved in Newcastle, when they wrote it up, and the model was very similar to what we have now in terms of PCN teams. One of their main findings was that, as the professor said, the intervention was the link worker. So people often worry, I don't have anywhere to send people, but actually what was making the biggest difference overall was being listened to, being somebody that somebody could go try something, maybe come back to and talk it through if it didn't work, just a sort of sense of a kind of non-medical real life interaction that provided some emotional support or practical support rather than emotional. So my top tip is don't be worried about it. Just go in there and talk to people.
That's such a brilliant presentation. Thank you so much, Nicola. I'm going to move on to, are you around for the next 5 minutes? If people have got any questions, they can pop back.
Yeah, no, I'll stay on for a bit.
So yeah, if you've got any questions for Nicola, then please do pop those in the chat. There was talk, Caroline was obviously appreciative of the information about kind of the nurse practitioner support in the early stages. And I think Sandra, do you want to introduce yourself, our next speaker?
Yeah, hi everyone. Hi, thanks Lianna, and thank you to Nicola for a really good introduction to the session. So my name's Sandra Dyer. I'm a primary care lead nurse at the cancer team within Healthy London Partnership. And I'm also an advanced nurse practitioner in primary care. So I've got sort of two hats, as it were. And I've had an interest in cancer now for the last sort of 7 years. So I'm very much a sort of generalist. I'm not a specialist, but I've just developed a little bit of an interest in this area and worked on various projects around it. So I was hoping to talk to you today, and there's probably a little bit of overlap from Nicola's slides, but hopefully I'll also add to kind of the discussion really in terms of my my emphasis. So I was going to sort of talk through what we call sort of the personalised care pathway, so the interventions that get offered to patients when they're diagnosed with cancer and during their treatment and afterwards. Some thoughts about how we work better together, so working as a team, and I think that picks up on some of the points that as Nicola's already kind of discussed. And I'm also going to talk about some kind of resources around sort of best practice, so things that you might want to use with patients, or some further sort of training opportunities if you're interested. You go on to the next slide. So I'm sharing this again. I know this was on Nicola's slides, but just to kind of illustrate really the sort of wide range of needs of people living with cancer. So this data comes from something holistic needs assessment, and these assessments take place at the point of diagnosis, at end of treatment, and at other sort of significant points. And because they're done electronically, we can kind of collate them and see what the top 10 are across London. So I share them because it kind of shows that there's a really wide range of needs. So they're definitely not all medical, they're not all practical, they're not all emotional, they're a whole range. So I think it needs a team to kind of manage these needs and try and meet these needs with patients. So I don't think any one person in the team, either in primary care or in secondary care, could help somebody living with cancer with all these needs. So I think very much, I think we need to think as, you know, how we can do this as a team. Go to the next slide. So I was just going to talk through the interventions that get offered to somebody after they're diagnosed. So holistic needs assessment we've already talked about. What should happen is that a person gets to fill in either a paper-based questionnaire or an electronic questionnaire called a concerns checklist, and I'm going to show you what that looks like in a minute. And then that kind of sets the agenda for their meeting or consultation with the clinical nurse specialist, or sometimes that might be a support worker within the hospital. These are pretty much always carried out in secondary care in London, to my knowledge. But what should come out of them is a care plan. And that care plan is shared with the patients, but increasingly will be shared with primary care teams as well. I know there's definitely some really good work happening in South East London at the moment to make sure that that happens, and I suspect that will happen increasingly. So a really useful tool for us to have sight of. And if you're seeing somebody who's you know, they're diagnosed within the last sort of 12 months, they may well have a care plan, and that might be quite a useful thing to take a look at. In terms of, you know, what interventions they've had already and what support they've been sort of signposted to already, just to kind of avoid duplication and have some sort of continuity of care. The second thing is treatment summaries. These are much more for sort of medically focused. It's a document that's produced by the team that's looking after the person in hospital, and it basically outlines what their diagnosis is, what treatment they've had, and what the intent of that treatment was, or was it curative or palliative. So that's quite a useful thing to know. Side effects they might have had so far, but also what to look out for. So, you know, what sort of side effects should the patient be kind of mindful of and thinking about they need to let someone know about, and also thinking about sort of recurrence of the cancer. What is it they need to look out for and to be concerned about? And the focus is very much, as I said, on physical, maybe some psychological needs. I don't think it looks very much wider than that, but it's a very useful tool for us in primary care to have sight of, and patients too. The idea it's a sort of patient held tool as well, so they know kind of you know, what's happening and what they need to report. And then health and wellbeing events. So in COVID times, these are all online, but basically they're kind of interventions to help kind of support self-management in the future, and it's kind of signposting people to services that are available out in the community, and it will help them kind of when they finish treatment. So they've perhaps don't feel like they've fallen off a cliff edge, and they know kind of what's out there to support them. And then the final bit that Nicola mentioned was cancer care reviews. So these are the bits that happen in primary care. And there's kind of two parts to this intervention. So one is contact with the patient at the point of diagnosis. And that could be a letter, it could be a phone call, it could be a clinician, it could be a non-clinician that contacts the person. But basically it's kind of recognising the diagnosis and offering support to that patient, and signposting to other services that might be available. And then the cancer care review, this needs to happen within 12 months of a diagnosis, and this should be a kind of conversation between the person living with cancer and either a general practice nurse or a GP or another member of the clinical team. I think best practices, we kind of prepare that person for that conversation. We can use something similar to the H&A document, so a concerns checklist. And the idea is, again, in my opinion, sort of best practice is that, you know, it should be patient-led and it should be kind of based around the needs of that person. And the idea is as a conversation and it's holistic is the sort of best practice approach that we're trying to promote. Go forward to the next slide. So in terms of how we might work together, and some of these points were picked up by Nicola. So I think the first one is sharing and being informed by the holistic needs assessments and the care plan. So having sight of that might be something that's quite useful for you as social prescribers. And certainly if we're getting them in primary care, I don't know to what extent you have access to EMIS or the patient records. That's something I'm not too sure about, but hopefully you do have some information that's shared with you when the person's referred, and that's something that would be a very useful thing for you to have sight of. The cancer care review, I personally think there could be a place for social prescribing within that, not in terms of the medical or the health aspects, but you know, those sort of wider needs that we know people have around you know, sort of social support, around finance, etc. So a sort of joint approach to cancer care review could be a really good model, I think, with social prescribers. The concerns checklist could be a useful tool for you, perhaps. So certainly to be aware of. This is what we could use for cancer care reviews, and it's very similar to what's used in the hospital for the holistic needs assessment. There's a screenshot of it at the bottom of my slide. It's probably quite small, so I'm not sure if you can see all the detail, but essentially it enables the person to kind of identify what their needs are and what they'd like to talk about in that appointment. And again, you know, it's something that you could perhaps use if you thought it was useful, if you had a meeting with or assessment with somebody living with cancer. And I think the kind of my kind of message here is that, you know, it's a team approach. So if the person was identifying lots of physical concerns, clearly we're not asking, we wouldn't be asking social prescribers to try and meet those needs, and it would be a case of kind of, you know, signposting that back either back to their clinical nurse specialists if they're still under secondary care, or if they're now having their care in primary care, referring them back to appointment with GP or practice nurse. So very much see that as a sort of a team approach to meeting those needs. And I was going to mention a couple of other resources here before I finish. So one is the cancer care map. This is a really, really excellent resource. It's a national database of services available to people living with cancer. And basically you can put in a search term such as, I don't know, benefits advice, for example, and a geography, so I don't know, Lambeth, and do a search, and you'd get some relevant services coming up. So it's useful for us as clinicians or as link workers, but also useful for patients as well, because there's some really good kind of patient stories and videos of people that have accessed services, and it's a good way of sort of selling you know, what might be useful to individuals. The Cancer Wellbeing London is a list of the health and wellbeing events that I mentioned. So if someone's asking about that, you can signpost them to that website, and they can do a search to find out what's available in their area. And finally, I was just going to mention the Primary Care Education Toolkit. That's something that's run by my team, and it's basically a kind of database of sort of training and education available around cancer across London to the sort of multi-professional audience. So there might well be things there you'd find useful as link workers or social prescribers if you wanted to kind of learn a little bit more about cancer. So I just thought it's a useful thing to signpost you to. And then lastly, I was just going to mention a letter template, which is on the right-hand side of my slide. And this is a kind of template letter that could be sent to somebody at the point of diagnosis. It was produced by Macmillan. But I'm just kind of highlighting, it kind of suggests there that you might find social prescribing helpful, and a sort of suggestion that they would contact the practice if they wanted to be signposted to that service. So I think it's just an example of a sort of integrated approach to how the team might look after a patient at the point of diagnosis. So I'm happy to take any questions.
That's amazing. Thank you so much, Sandra. There are so many wonderful resources that you are sharing there. And I know that having spoken to link workers, a number of the things, especially things like the cancer map, have been really helpful in the work of link workers. I'm conscious that you have another meeting to go to, but do you have time for a quick question if anyone's got a question or a reflection?
Yeah, that'd be fine. Yeah.
Any questions from the audience?
No question.
Really helpful.
It's just brilliant. It was just brilliant. That was so helpful. And I love all those resources. Thank you so much.
Great. Glad it was helpful.
Thanks so much, Sandra, for your time and joining us today. I think, yeah, we'll be sharing all of the stuff that's been discussed today. So, yeah, that will be on its way over to you with the slides, everybody.
Lovely, thank you.
So we've got a video now from the Hammersmith and Fulham service. They wanted to be with us today, but unfortunately have, well, fortunately for them, I guess, have been nominated for the Macmillan Award and have travelled up to Manchester today, but they wanted to share a video of their service with us. So if you could pop that up, Justina. Some of you may be familiar with this already.
Cancer can affect every part of someone's life. It's not just their physical health, but cancer can affect people's emotional and financial needs. And it can be difficult sometimes because you don't always know where you can turn or where to access help and support. A lot of their treatment and support is going to be within hospital. Afterwards, when they've maybe completed their treatment and they come more under the care of the community, such as GPs and the rest of the team within the community, they may feel that some of those needs are not met anymore, and it can feel a bit lonely when you're discharged from hospital because you don't have somebody there checking on you. Patients are people, they have lots of non-medical needs and they're incredibly important, and the only way to actually help somebody fully is to understand that big part of their life, and that's where the link service really comes in. There are a lot of people that come to us as their GP just for non-medical help. They've got a lot of non-medical needs, and there is a big crossover between people's kind of physical and mental health state and also their kind of holistic care. So thinking about their financial needs, spiritual needs, and housing needs. And when somebody's in trouble socially, it often kind of, you know, filters down into their physical and mental health needs. So there's a lot of overlap. This is great for me as a GP because I know that I can safely refer one of my patients there. They'll be seen by a link worker, they'll have a proper assessment done, what we call like a holistic needs assessment, and be able to actually walk patients through those kind of services and signpost them to those kind of services that can help them in the way that I can't. Anyone with wellbeing concerns can get a referral into the link worker service. It's very easy. All they need to do is speak to their local GP, like myself.
So my name's Yvonne. I'm the Macmillan Partnership Manager for North West London. It's a sad fact that 1 in 2 of us will receive a cancer diagnosis during our lifetime. One of Macmillan's primary aims is to ensure that every person diagnosed with cancer receives access to services that provide personalised holistic support, addressing the practical, emotional and physical needs that come with a cancer diagnosis. And the Hammersmith and Fulham Link Service provides just that. So the Hammersmith and Fulham Link Service project is a partnership between Macmillan Cancer Support, the Hammersmith and Fulham GP Federation, local hospitals and the voluntary and community organisations in Hammersmith and Fulham. We also provided cancer training to all of the link workers so that they felt confident supporting people with cancer and were familiar with both the local services available to cancer patients and Macmillan services. Alongside this, we facilitated opportunities to bring together professionals from primary care, from secondary care, from the local voluntary and community settings, and from patients themselves in Hammersmith and Fulham.
My name's Helen and I work for the GP Federation in Hammersmith and Fulham. So the Link service provides support for people beyond their immediate medical needs. Financial support, practical support and significantly emotional support. They can work with people on a one-on-one basis and signpost them to additional forms of support, be that befriending services, local authority or voluntary and community organisations. What this service has enabled people to do is to find those connections in a way that they might not necessarily have been able or motivated to do on their own.
My name's Alison Boyd. I'm the Macmillan Information and Support Centre Manager here at Chelsea and Westminster NHS Foundation Trust. We see a lot of patients and families day to day who have lots of practical, lots of emotional, lots of psychosocial issues that we can address, but it's really nice to have another alternative service that we can refer people onto if we feel they need more tailored support and personalised care in their community and in their borough. And that allows people to also look at identifying non-clinical support. Those are the things that people need, wherever they choose to access it. You know, it's good to have that choice.
My name is Violeta and I am link worker. I heard from my patient about a year ago. He was referred by GP and we started working together. I speak to my patient when there is a difficult time, emotional time. I am there when he needs something. He contacts me and say, oh, can you help me with booking appointment for blood tests, or can you help me with transport to hospital? He's very grateful and this makes me feel happy and fulfilled.
Czy 200% na pewno pani Violetta pomogła mi w tym i tak dalej, bo jeżeli się wyczuwa, że ma się koło siebie osobę życzliwą, to naprawdę to pomaga, bo sama myśl tego, że jeżeli jakiś problem się zdarzy, no mam do kogo się zgłosić. To taki kontakt, tak jak z panią Violettą, to tak jakbym miał drugie serce wszczepione. She's angel.
So we've created what we call a bit of a cancer work stream, and so I would like to see, or I would hope to see in the future, that that's embedded, and when a new link worker comes in, they'll get a bit of that education which we've developed moving forward. Before we had a service like this, there's a lot of kind of internal frustration that I can't help this patient as well as I really want to, and I wish this service was around. When we create a service where there's a clear need, then it feels like we've made a difference. We really do need the link workers because they really do kind of add a lot of value to our team.
One of the key successes of the project, and this is an ongoing piece of work, is establishing really strong relationships between the link workers and other organisations. I've been really impressed by the determination and dedication of the link workers in supporting people to really ensure that they get what they need.
As those relationships develop and improve, there are more opportunities planned to bring primary care and secondary care together. It would be great to see services like this across London, really focusing on the support that's provided to cancer patients, looking at what local services that they have that support cancer patients, including what's on offer in their local hospitals, and joining that all up so that all Londoners that receive a cancer diagnosis get joined up, integrated, holistic and personalised care.
We are in the beginning, and I think it's very exciting to think what we could achieve in 6 months to a year, you know, crossing the boundaries between, you know, us here in the hospital and the community organisations. Joined up working is definitely the way forward for the patients.
Really, what a wonderful video, and really heartened to see there's so many aspects of that which I think are important for social prescribing. It's the joined up working, it's the, you know, the thinking about the future of social prescribing, linking in with the hospitals and being able to take referrals from all sorts of places. I realised as I was watching that video that I've met some of the link workers that are part of that programme, and the link workers are not actually specifically only working with cancer patients, but because of this additional sort of wraparound support from Macmillan, as the doctor was explaining at the end, there's real value for getting some of this focused training in the initial stages, and then that proliferating through the service. One of the things I wanted to pick up on was the link worker who was giving the example of their role. I think as we're starting to see, I'm noticing within the system, people are really interested in about how the three roles work together. And it's, I think, really the role that the link worker described there supporting that patient almost feels more akin to the work of a care coordinator. And perhaps this is as primary care networks start to recruit more of these roles, we'll start to get a better distinction between what each of those three different roles, the health and wellbeing coach, the care coordinator and the link worker, can be doing, which leads me nicely on to, I think it'd be really good to get an example of from Hannah Jackson in Wandsworth, who is a social prescribing link worker who has since evolved into or moved into a role that's specifically supporting cancer patients. Hannah, do you want to introduce yourself?
Yeah, of course. Thank you all for having me. It's been so nice to be here today, and it was really great to see the Hammersmith and Fulham video. I enjoyed that very much. Yeah, so I was just thinking as I was watching it, I've never booked somebody a blood test before as a link worker, but it's really interesting that the role is different in different boroughs, isn't it? Yeah, I am the Macmillan community link worker in Wandsworth, so just along from Hammersmith and Fulham. So I used to be a GP social prescriber, so I did that for a year up in Putney and Roehampton, and then I moved this time last year into this Macmillan roles that I've been piloting ever since. And so I guess in order to sort of do the cancer specialism, I've had a lot of training with Macmillan. I've done lots of other sort of cancer modules like motivational interviewing for cancer patients and different things like that. So, and I think a lot of the specialism has really just come from working with cancer patients all the time. So I guess the aim of my role here in Wandsworth is to improve the awareness of, access to and uptake of services available for those living with cancer and also their carers too. So in my role, sort of, I'm connecting people to cancer support services, and that might be in hospital, it might be out in the community, it might be nationally. There's a lot of national cancer support available too. And there's a very embarrassing picture of me on this slide as well. Can I have the next slide, please, Justina? So yeah, here how it's working in Wandsworth is that I'm getting my referrals from GPs, and then we have a triage system with all the link workers in Wandsworth, and so they send their cancer patients on to me. And we've also done a little bit of training in Wandsworth to upskill the link workers to be able to support cancer patients too. I'm receiving referrals from 42 practices, and so I can't take everybody, and so the idea is the link workers can provide that brilliant support as well. And so unlike my GP link worker role, I'm now based in the community. And so I see clients at my office in Battersea Park, which everyone really enjoys coming to. And then I'm doing lots of Zoom and telephone support as well. I also am based in the local cancer support centre called Paul's, 1 day a week. So it's quite nice to be able to offer this service away from the clinical setting, and that's been sort of a key part of the pilot, was bringing things slightly away from primary care, but still working with them and making sure that we're getting these referrals through. So I use Elemental to record my patient data. I'm using, I don't know if people maybe on this call, probably you've heard of these before, but I'm using the ONS4, which I think lots of link workers are familiar with. And I'm also using the EQ5D measurement tool, which is a really good one. I really enjoy using that one to track our outcome measures. What I find, and what I'm sure if any of you are familiar with the ONS4, is that often the questions feel slightly inappropriate for different points of the cancer pathway. And so for me with the ONS4, I'm trying to concentrate on those patients at the end of treatment, because that questionnaire asks things like, how satisfied are you with your life at the minute? And I feel like to ask that question while someone's sort of just been diagnosed with cancer feels totally inappropriate. And so that's when I would use the EQ5D questionnaire instead. So I'm lucky to have a little bit of flexibility there. Justina, can I have the next slide, please? Thank you so much. So I'll give you a really quick case study, but I think I'd rather get onto the tips because I think that'll be the most important thing. Some of it is repeat information. I'm just hammering the messages home from the other speakers. But I guess for a case study, just an example of someone I might see, and just to note, I see clients from all sort of stages of the pathway, so from initial diagnosis right through to palliative, and it sounded like some people were quite interested in how we can support palliative patients, and I'll talk a little bit about that in a minute. But I guess a case study of someone I've supported is a 62-year-old male with prostate cancer. He's been initially diagnosed. He hasn't even got his treatment plan yet. He's brand new diagnosis. He's had his diagnosis letter from the GP, and that's as far as he's got. He's feeling totally overwhelmed. He's really worried about the future. I think a really big concern that you might see all the time is people who are worried about dying and whether this cancer is going to kill them, or whether, and I think when he hadn't received his treatment plan or even the stage of his cancer diagnosis, that was something that he wasn't sure of. And so we had this obviously supportive initial consultation. We had an hour together to talk through his concerns. I would ask my measurement tools where appropriate, and essentially we came up with some things that were important to him and concerns that he might have, one of which was keeping active, one of which was the impact that his diagnosis would have on his family. And so through this sort of holistic approach, we identify these concerns. And then my actions as a link worker, just if you could change the slide, were as follows. So that might be to identify, first of all, that he had some medical questions, and he actually, this particular gentleman hadn't been given a CNS yet, a clinical nurse specialist. And so he had obviously spoken to his GP a lot and was feeling, I don't want to bother the GP anymore. And so sometimes it might be appropriate if it's just a little question and they feel, they've exhausted other support, that some of the national charities, as Nicola mentioned at the very beginning, like Macmillan, have nurses on their lines where clients can call and just ask if they had a really quick question like, what can I eat? Things like that, then they might be able to speak to a nurse. So the Prostate Cancer UK have a line where they can speak to nurses if they have more sort of generic queries that aren't necessarily specific to their journey. Also, the hospitals often have psychological support available. So in this case, it was signposting him to the support at the Royal Marsden Hospital. Lots of the hospitals in Wandsworth will have some kind of psychological support available, even if it's just a Maggie's centre in the grounds. Maggie's is a sort of national charity, and they have drop-in support centres, often in the grounds of hospitals. So it's really worth looking up your local Maggie's centre if you don't know where it is. Because what I find is if you're referring someone with cancer to psychological support, sometimes there might be 2-3 month waiting lists to get that support. And so I think Maggie's is a great place to recommend if someone just needs a bit of drop-in support and wants to talk to someone straight away. If they pop into Maggie's, they can speak to a cancer support specialist, and they can also find out about sort of support groups and courses and wellbeing activities that they might be able to sort of take part in. So I couldn't advocate Maggie's support more, it's amazing. So yeah, and then I guess there is the National Safe Fit initiative with Macmillan, which is sort of support keeping active where you've got cancer. And then we have a local wonderful support service that we run at Enable called Macmillan Move More. So yeah, worth checking those out. And I guess the cancer care map is the best way of finding out what's near you. So I guess we'll get onto my tips because I feel like this is the best bit. So I guess what you've already heard, all clients have a clinical nurse specialist. As link workers, you might get a referral for someone who has all these medical concerns and you feel stressed because you're not really best placed to cope with that. And so I think it's always about signposting back to the CNS. Again, you might get a referral from a client after they've had a cancer care review with their GP, and the GP might have identified different concerns as a part of that you can help with. So yeah, it's just another list of what cancer clients have access to. I guess, yeah, in terms of a good sort of thing to do is, if you know the client's diagnosis, it's worth checking out the cancer specific charities. So if they have a brain tumour, it's Brain Tumour Charity. If they have bladder cancer, it's Bladder Cancer UK. So there's loads of different sort of specific charities that I think it's helpful to recommend for people. And they often do things like lots of online information, online chats, helplines, sometimes support groups. So that's a really good thing to recommend. I think consider the in-hospital support available. So research your local hospital. If the hospital doesn't have a Maggie's, it might have a Macmillan Information Centre, which often sort of does similar things. It might have, like Guy's Hospital, I know, has sort of a cancer centre, Dimbleby Cancer Centre. So yeah, just have a little look and see what your hospital has to offer. Down here in Wandsworth, we have St George's, they have a Macmillan psychological support team as well. So often, I think when I was a GP link worker, I didn't have any idea what was going on in secondary care, so it's good to flag that you should have a look. And then I guess just in terms of the palliative stuff, I think I totally agree with Nicola. Sometimes when you get a palliative referral as a social prescriber, it's terrifying because you think, gosh, I'm just not sure that I'm best placed to help with this. And so I think the most helpful thing really is to link in with your local hospice. Here in Wandsworth, it's Royal Trinity Hospice, but I think it will differ depending on where you are. And if you link in with that hospice, often if you try and help a palliative patient without getting in touch with the hospice first, you're actually duplicating their work. And so if hospices have been really open to me sort of emailing and saying, oh, are you involved? If they say, oh, I think I'm under Trinity Hospice, but I haven't really spoken to them for months. Sometimes what happens is that the patient will speak to the hospice and then say, oh, I don't think I need any support like that, because often hospices can offer more than just the medical support. They can offer counselling, they can offer physiotherapy, all kinds of different things. And the patient maybe just isn't ready at the point that they're referred to take it up. So sometimes I've had patients who've been referred to me who said no to Trinity support at the beginning, and then down the line they've gone, oh, actually, I think I do need some counselling. I think I do need some other kind of support that the hospice actually can offer. And then I just link back to the hospice, and I would maybe email the hospice generic email and say, please, could you give this client another call to discuss X, Y, and Z. I have sort of different professionals. I know there's care coordinators at my local hospice who are brilliant. There is a benefits advisor. So I think sometimes it's just about linking in with those palliative services instead of trying to take on the work yourself, particularly referring to then your community support, like say you refer them to Citizens Advice when they could easily have talked to the benefits advisor at the hospice. So I think it's just about making sure that you know who's involved before you try and help. I think it is scary getting these palliative referrals, and I think the best advice that I heard from some training on death from Macmillan was that I think something that is quite common is maybe to have the client sort of alluding to death, but maybe not saying it in so many words. And I think to actually identify death and not use euphemisms like they've passed away or lost their life, or I think to be direct about it is the best advice that I've heard, because I think things can be miscommunicated. It's better just to be open about death with the client, which I think is a very scary thing to have to talk about. And I think I found some really good resources on Marie Curie website, if ever you're interested in having a read about sort of talking about death with people. They have some great stuff. But yeah, I think no, it is definitely frightening, and I don't think necessarily it gets easier. But I hope that looking up those resources will help you. And I just had a final page which had some resources that I found really helpful in supporting cancer clients. So there's the Macmillan support line, Shine Cancer Support supports people in their 20s, 30s and 40s. So I think there are loads of different cancer support options, and the Cancer Care Map really is a great place to find it. What I also find is people don't really know what Macmillan do. They sort of say, oh, I spoke to someone from Macmillan, and so I think that, you know, familiarise yourself with the services Macmillan provide. In particular, the Macmillan Grant Fund is fantastic. That's small grants for people living with cancer if they have, I think it's less than £8,000 worth of savings. And so if you have someone struggling with their finances and they haven't had a Macmillan grant, I would encourage you to either tell them to apply independently or get them someone from a benefits team to help them apply for that. So yeah, I'll stop banging on. I could talk for ages. But if anyone has any questions, please feel free to ask.
Hannah, there's lots of love for you in the chat right now. I think this is so helpful. I think this is why it's so important to hear from people that are doing the role. Has anyone got any questions for Hannah? Link workers that are maybe working with, have been given some cancer referrals and are keen to sort of understand a bit more about anything in from Hannah's presentation.
Can I just ask a quick question, please? So obviously you mentioned about the conversation about death, and my kind of experience of it is being referred someone who was stage 4 and not being given really enough information, and the GP wasn't there when I was first speaking to them. I also didn't have access to EMIS at the time because it was all remote during COVID. So I didn't really know how to approach the conversation, because I knew that she had stage 4 cancer, but that doesn't, I don't always know what that means in terms of kind of life expectancy, whether it's, you know, curable, whether it's not, what she's been told. And I didn't quite know how to ask the question because I didn't want to trigger anything in her, but also, you know, it's helpful for us to know kind of where someone is in their journey so we can signpost them or send them to the right place for support. So I don't know how you go about asking those questions sometimes. It's quite a difficult topic to ask without triggering someone. So yeah.
Thank you so much for your question. I think it's really, really difficult to get to the bottom of it, particularly when GPs are so busy. Sometimes they don't put lots of information on the referral, and you can't see things that you've tried to look on EMIS, or maybe you don't have access. It is really difficult, I think. And I guess the best tip that I have for doing that is, because I also don't have EMIS access, is to ask the client what their sort of either their oncologist or their clinical nurse specialist has told them. So yeah, I think it's really scary to sort of, you know, maybe they've said something which sort of implicates that they might only have a little bit of time left, but it's a really difficult thing to ask directly. And so I think the best thing is, first of all, to say, could you tell me a little bit about what the doctor told you about what stage you're at, and sort of, I guess the two options are whether the treatment is curative or palliative. And so you could feel free to say, are you on a palliative care plan? And they might say, oh, I don't know, no idea what that is, in which case you just say, what did the doctor tell you? Did they tell you that the treatment that you're on is going to cure you? Is it going to be curative treatment? So I guess that's sort of, I try and give as little information myself as possible because I'm not qualified, and ask them to relay what people have told them instead. And I find that quite helpful, because often I think sometimes, you know, clients are hearing from their doctors or whatever, and they don't actually fully understand it themselves. And so sometimes actually to echo it back to you is really helpful for them and their understanding of what's going on. So yeah, I guess my tip is to say as little as possible yourself and ask them to relay things, but also, like, do not, you know, I think it's putting you in a really difficult spot if the GP sent you really little information, and so feel confident emailing and saying, could you let me know? I think a good question to ask GPs is, could you let me know about their prognosis? Because sometimes the GPs don't even know themselves, but they might have some idea of how long they might have left. And so that's a good question for the GPs if you're asking them. Oh, I'm banging on, haven't I?
That's really helpful. Thank you so much.
Any other reflections or questions? we've got a bit of time left, so I was thinking we could, I mean, it might be that you have questions for each other or some examples.
I just wanted to thank Hannah for bringing up the area that I was concerned about. It's not happened a lot. I've only had 1 or 2, and it was just by accident. And I, like you, I didn't have the background available until I got into the conversation. Then silly enough, eventually I realised when I went back into the notes that this was the situation with this particular patient. But again, you sort of go into it slightly blind. But I think, yeah, I just appreciate Hannah's view on and recognising that I'm not the only one. Thank you.
We've heard from a really good range of speakers today, and I just wanted to thank Jason Tong from the cancer team at Healthy London Partnership. I feel like this is very much an ongoing piece of work, thinking about how social prescribing connects with supporting cancer patients. We've had some brilliantly some insightful presentations from people in different parts of the system and some great tips. Just thinking, we've got 20 minutes left, and so what we normally do with these sessions is to perhaps open it up to the group and see if anybody's got some reflections, comments, cases they're struggling with that they want to share with the other attendees, or perhaps even some questions that you've got for your peers.
No, I just wanted to say that I feel a lot more confident now. It's a bit scary at first when you think, oh, cancer, because it's such a horrible disease, and so many people die from it every single year, and it affects, like you said, us in our own families as well. So there's a little element of trigger in there as well. So after having sat through these presentations, I definitely feel a lot more confident now, knowing a lot more about it and what resources are out there. Yeah, thank you very much, Hannah. Your presentation was amazing. I loved it, and I loved the film as well. It made me cry.
You raise a really important point, Caroline, actually, that I was sat in on a conversation about some of the cancer support more recently, and there was a comment about how we think that cancer's very serious because we hear about it a lot in the media. But I was thinking also, it touches us all in our own lives, and it's very important to recognise that if you have had a personal experience with cancer, either yourself or with family members, that it could be difficult. There could be an added layer to kind of what it brings up in you when you're supporting individuals that are going through that process. And I think it's a good opportunity to remind you guys to, if you feel in any way that it's affecting you emotionally, that to lean on your clinical supervisor, or to access some of the free counselling that's available to NHS workers and people that are working in your roles.
Yeah.
I can see Nicky's taking herself off mute.
Yeah, I just want to make a slightly more positive point. Sorry, my computer died in the middle. But lots of people get better from cancer.
Yeah,
it's actually, it's better to go in with well, not better, but there's lots of circumstances where people are going to have the treatment and be well again.
Survive,
and,
yeah.
And so just bear that in mind, because I think the discussion about cancer always ends up talking about misery, and sure, it's not great, but lots of bad things happen in life and people get over them. And I think there's an element of that just to bear in mind. The other thing that struck me was that you could have, if you've got the time to go on one of the Cancer Research UK Talk Cancer programs, which are being rolled out certainly around a lot of the country, it's worth knowing about the different screening programs, because you'd have the opportunity in lots of settings just to throw in, have you had your mammogram? Have you, done your bowel screening? Because prevention is the great, it's where we should be, hopefully, in the future. And you do, as meeting lots of people in the community, loads of people don't take up the offers of screening, and it's just a missed opportunity. So just, if you're able to do that, that'd be a great addition to
We've got a good question from Claire. Typically, what's the time frame between diagnosis and being allocated a CNS? Is that something you're able to answer, Nicola?
Yeah, on the whole, people don't get allocated to CNS until they've got a diagnosis specifically. So if you go in with symptoms until you've had the investigations that confirm the diagnosis, you don't, in our area anyway, tend to get the nurse specialist until that point. And that's a difficult area that we have brought up with Guy's and St Thomas's, because when there's uncertainty in the diagnostic process, people are a bit left in the lurch. And during that period of time, the GP should be, your support.
Does that answer your question, Claire?
How long can a diagnosis take? I've got a patient who seems to be just sort of, there's a lot of waiting involved.
Yeah, it depends on the available services and what's going on in each area in terms of access to diagnostics. There is an aim that everybody should have had their first treatment by 62 days from their initial referral. So not have the diagnosis and actually have started some form of treatment. That's a national target. Most people, I guess, would get a diagnosis within, I don't know, there isn't an exact answer, because say, if it's lung cancer, you could have a chest x-ray and you've got, you've got that. Breast cancer, you could go to a one-stop clinic and have a biopsy and they might have the diagnosis in 3 days. Other things are just more complicated and not as immediately obvious as to what the problem is. So some people will be going through rapid access diagnostic clinics because they've got maybe some weight loss, some tiredness, and it's not clear why that's happening, and they're going through a number of different investigations. To say cancer, we're talking about a huge range of illnesses, really. So there isn't a single answer to that.
Thank you, it's really helpful. I think you raise a very important point, that there's lots of, the treatment for cancer has come on leaps and bounds, and I guess the role of the link worker in this process is about whether, waiting well, and where people may be waiting for a diagnosis or are dealing with some of that anxiety. It's thinking about what how we can connect them with wider support community services that can make them feel less isolated. There are lots of things that I guess link workers, the superpowers of the link worker can come into their own with whilst somebody is waiting for those sort of life-changing results. Iram, you had your hand up. I just wanted to come to you quickly before we go to Shmal.
I did. The question I was going to ask Hannah was, when somebody's had, sort of a new diagnosis and they're sort of in shock, or, they experience a bit of trauma just because of the whole, you have cancer. I was thinking where to send those patients. I know you mentioned Maggie's. What's your opinion? Would you say that that's one of the places that I could start with?
100%, yes. Because it's drop-in, it's quite nice because people can just pop in a weekday. So I would say our local Maggie's is Hammersmith and Fulham, and that's open 9 to 5 every weekday. And so if someone wanted to pop in, but what I find with the clients at initial diagnosis is often that it's not the right time to be referring them anywhere else, because they're so overwhelmed with getting sort of information, getting sort of trying to find out their treatment plan, and it's sort of it's a really stressful time. And so often I find just being there to listen to them at that sort of initial stage is enough. And then perhaps once they have their treatment plan, they'll then say, right, I'm ready to access support now. So I think just with the initial clients, maybe sometimes don't push support on them if they just need a chat with you, because we're all, of course, best placed to be able to listen at least.
Yeah.
But if they sound like they need the psychological support, you can make that referral too.
Yeah, also, someone just mentioned about the breast cancer. So there are some one-stop clinics at the moment. I know there is one locally where I live, and I thought it would just, it would be great if, they have a room where they let people know if they have or don't have cancer. So, you see people coming out and they've either got good news or bad news. And at that point, if we can have social prescribers there and saying, doing a bit of hand holding and just saying, look, there are options. There is someone you can speak to. I mean, that point where they're told and they leave the room, it's a time where you really need someone. And I hope that social prescribers can be put there in those clinics, or at least have sort of information available on what to do next, so that those patients don't necessarily fall into a trap of depression. As Nicola said earlier, cancer's everywhere, and we shouldn't think that it's going to be the worst outcome. You don't know what the outcomes are, and it's an illness like any other illness. If we could just have somebody just tell you, not that it's going to be okay, not to give any sort of false ideas, but to say, hey, it really is going to be okay, but first we've got to do this, let's have a chat about this and see what the person's own opinions are. I think some of the beliefs around cancer are like, it will never happen to me, but it's happening. You hear about it quite a lot. So your presentation was great. It was really helpful, because I do get stuck with a lot of patients, and I think, okay, you've got to sort of, you have this moment where you think, don't say anything that's going to possibly offend someone or upset somebody. So you've got to be so careful and think about what you're saying. But ultimately, what's great is that there's so many places out there that can help and sort of step in and help us and help them too.
I think there's a couple of things within all of this. There's, first of all, it's linking up with each other. You're going to be dealing with these kind of cases all, ongoing, and making sure that you're accessing peer support either in your local borough, or some of the sessions that we run Pan London, they're drop in every other week. If you're struggling with a case, feel free to bring that. We run action learning sets for individuals that are struggling with a particular client, or maybe kind of a broader issue in their work. The other thing is, you guys can't wave a magic wand. We say this so much. There's only so much you can do. And I think Hannah was talking really importantly about the power of listening, and how just being connected with a link worker sometimes can be an intervention in itself. And we especially that was especially highlighted during COVID. I think it's also, as we've got the new personalised care roles coming into the system as well, we've got health and wellbeing coaches and care coordinators. It's thinking about how you as a social prescriber can be connecting and referring back to other roles within your system. So actually, in those early stages where somebody might be having quite a traumatic response to getting a diagnosis and feeling a bit at sea, perhaps the right person to be supporting them at that time, especially if they've got more complex, broader needs, health needs, or we feel like they've got, perhaps they're a carer, perhaps they're quite overwhelmed in their life more broadly. Perhaps a care coordinator could be a good person to be connecting that person, supporting them, making sure that they understand when all of their appointments are, and can be hand holding them through the process of getting the right health support that they need. And perhaps a social prescriber, the care coordinator might then further down the line refer that person back to the link worker when they are a bit on more stable ground and are ready to sort of consider the more social aspects that might have been affected as a result of their diagnosis. Shamal.
Hi, Lianna. Thank you so much for the presentation. I did come in a little bit late. I just kind of want to share a few things, but just kind of also get a bit of information from probably the group as a whole. In Waltham Forest, we've had, I suppose, an indirect connection with Macmillan Cancer. Basically, at Whips, we have, they have a Macmillan Cancer base there, and we have connections to Macmillan Cancer via Tower Hamlets. But something that I was speaking to a colleague who's actually based in A&E at Whips, and was mentioning quite concerningly that there's a lot of people presenting at A&E at the moment for cancer screening in in opposition to, say, primary care. And just wanted to see as a group where people may at PCN level be doing something that is having that conversation to let colleagues know at PCNs that we are around as social prescribers and can support and connect people who are affected by or living with cancer, and what they're doing, because I think there is a bit of a disconnect at the moment because of the way COVID has been. People are not going to the primary care as much, so we have social prescribers based in PCNs, but they're presenting at A&E, and that is quite concerning because it's putting burden on them. And what are people doing, and where perhaps some other boroughs and PCNs where it's working quite well, where staff know about services and social prescribers in Macmillan and can connect it, because I think in Waltham Forest there's a little bit of a disconnect at the moment. Thank you. Anyone?
Any comments? Any comments from the audience?
You've either cracked it or yeah.
Well, I could comment.
Sure.
That's a massive, difficult job that we've been trying to tackle in South East London. So you're not only starting from in hospitals, people don't. A lot of them haven't even heard of social prescribing because they live in a hospital community, and it's just not something that's entered their, their existence knowledge. We have in Southwark managed to set up one direct link between the head and neck team and our local PCN link workers. And we also were trying to do one in lung, but it didn't get going yet. We're working on that whole thing, and the idea is that we would make sure that all the tumour groups, all the hospital-based cancer services that are providing to our population in South East London, so 2 million, would know what it was, and that there was some way by which they could directly link to the PCN groups. But what's happening in reality alongside that is as social prescribing becomes more recognised and valued, they're getting more and more referrals, and so people are ending up very busy, and it's a negotiation process that we set up more directions by which they could, kind of be overwhelmed with input. So it's a holy grail of a direction that we would make this everybody to understand and know, but it has to be supported by enough investment alongside that the link workers are not drowning in the same way GPs are because of workload. So there's not an answer.
We know that there is more funding available. There is the ARRS funding is increasing year on year, and there are targets to grow link worker numbers. This is a very kind of like rough average, but it's four link workers per 50,000 population PCN by 23-24. And I think the challenge at the moment is encouraging PCNs to think in this growth way and see social prescribing links, see the value of social prescribing link workers and grow those teams, rather than think, oh, we've got one, we sort of tick that box, but let's look to the other roles now. It's thinking about how we can work alongside PCNs to really kind of underline the value of growing these teams. And certainly thinking link workers would, the role of the link worker is designed to be able to take referrals from the community, from secondary care, from the police, from the fire service. This is the next iteration of social prescribing. And now that the services are sort of in place within the PCNs, it's thinking about what processes do we need and what capacity do we need within the teams to be able to work towards a maturity that is sort of like taking a whole system approach. It'd be really lovely to hear some examples of where link workers are taking referrals from secondary care or outside of primary care, and how they're making that work.
Hi, Lianna, just going back to primary care in regards to just basically letting our teams know would be a really good thing, because I think we as social prescribers are aware of the support that's available, and it's really good to hear that there is some kind of funding and kind of work being done. But I do feel like we're missing an opportunity, and there may be people who are going obviously to A&E, but to be able to kind of connect them back to primary care, and then we can connect them to secondary care or wherever the referrals are coming. And yeah, just be really good to do some some learning around that so that we can tell our primary care network teams that we're there to support people living with cancer and affected by it. So it'd be really good to hear from other link workers.
Perhaps this is a session, we've got some gaps for these for themes next year, and I'm wondering whether or not taking referrals outside of primary care and looking at link workers that are taking a more advanced sort of approach to where they're receiving their referrals from could be a really interesting subject for next year. I think that's the sort of thing that we'd want to bring PCNs into as well. I mean, I think there's something around the operational process that link workers need to understand, and then there's influencing primary care networks to invest in staff that might work in this way. And I think that latter bit is, you know, hopefully something that we're going to be trying to do a bit more work around, but it's really important to get input from you guys around how you think we could be influencing the PCNs, or how we could be supporting you to influence the PCNs more importantly. We're coming to the end of the session. I hope you found this useful. I think we've got a feedback form that Justina's just popped in the chat. Really huge thanks to the speakers, Jason Tong and Sandra, for helping organise some of the speakers today, and to the link workers who've contributed as well. It's been really great to have you. Hope you all found this useful.